Hello, everybody, and welcome to Conversations in Lung Cancer Research, a TOGA podcast. My name is Mel Moore. I'm a medical oncologist at St Vincent's in Melbourne. I'd like to start by, on behalf of TOGA, acknowledging the traditional custodians of the land on which we live and work. We pay our respect to their elders past, present, and emerging. We also extend that respect to all Indigenous people. In today's episode, I'm delighted to be joined by Associate Professor Fiona Hegi Johnson. Fiona is a radiation oncologist at the Peter McCallum Cancer Center in Victoria and a senior research fellow at the University of Melbourne. Clinically, she specialises in the treatment of patients with lung and breast cancers, including a subspecialty interest in stereotactic ablative body radiotherapy, or SABR as it's known to most of us. Fiona is also the chair of the TROG lung subspecialty group and is the chief investigator on a number of clinical trials. Fiona's research, which is supported by a Victorian Cancer Agency fellowship, focuses on integrating biological and imaging information into radiotherapy to develop personalised, biologically driven approaches to radiation therapy. Fiona, welcome to TOGA's Conversations in Lung Cancer Research podcast, and thank you for joining us.
Thanks so much, Mel. It's great to be here. Lovely to catch up.
Fantastic. Fiona, I've been doing a few of these now, and I always start by asking the person that I'm talking to just give a bit of a summary of their career to date and their journey of how they've got to where they are now.
Well, I think in some ways I've ended up where I am. So I'm a clinical academic, and I spend around half my time doing research. I also spend 2.5 days in clinic doing clinical work. And I actually think sometimes I wonder how I got here too. I knew I wanted to be a scientist as a very little girl. And when I did medicine and then started training, by that stage, when I started training, I already had 2 young kids. And honestly, I didn't really see a path towards doing a PhD and becoming a scientist. But life pushed me, I will have to say. Life pushed me in certain directions. And then I was just really, really lucky. I was very lucky to finish my training in Sydney and to find a great PhD supervisor, Paul Keel, who's a physicist, actually. My PhD is in medical physics, which really opened my eyes to a whole different world because Paul, of course, leads an internationally recognized research group with, I think, about 20 postdocs. And it was a very, very exciting team to join. And at the same time, I was doing a part-time PhD with 2 kids. I think my daughter was 4 when I started my PhD, and working as a rad-onc fellow and then as a staff specialist. And it was sort of a series of happy accidents, I will say. So senior people leaving at Peter Mac and Trevor Leong essentially ringing me and asking me if I were interested in taking an academic position, or a clinical position could lead to an academic position. And then going to Peter Mac, where I got to start a postdoc program in imaging, but in PET-based imaging in biology. And I'd spent about 8 years thinking about CT and realized by that stage it wasn't what I wanted to do. So coming to a place where it's kind of normal to have coffee and talk about molecular biology was a very, very cool thing. So here I am after 6 or 7 years at Peter Mac as an academic at the University of Melbourne and as a clinician. Yeah, so if you ask how I got here, I'm not exactly sure. I think it was both accident, but it was also desire, and the recognition that I wasn't happy just being a clinician, that I needed more, and then taking opportunities as they came up, and wonderful, wonderful mentors, starting with Paul, but I think we'll talk about those wonderful mentors later on.
We certainly will.
Yeah.
And was radiation oncology a decision you made quite early on, or were you someone that had done a few years of medicine, general medicine, and then went into rad-onc?
No, I sort of made the decision, actually not for rad-onc very early, but it's an odd thing to say, but I really wanted to do palliative care. And it's an odd thing to say because I really wanted to do palliative care because as a little girl, I used to think a lot about dying, and I was kind of obsessed with the Brontes and all those morbid 19th century English novels. And I thought a lot about dying. And I really had this sort of attitude. I think I saw myself as Florence Nightingale, actually. But when I got out and started working, I realized I had to do some form of training before I had to do pal care. And I will be absolutely honest, I chose to do rad-onc instead of physician, so I didn't have to do cardiology because I sucked at it so bad. And I just knew I would fail if I was called to resuscitate somebody. I would just have massive performance anxiety and freak out. So I chose rad-onc instead as the default pathway towards palcare. And yeah, that's the honest truth. I'm really sorry.
Has you had any exposure to rad-onc, or it was
Very little. Very little. My
Wow.
mother was a radiologist and she thought it was a good idea, and she has no idea what's involved in all. So
That's incredible.
well, it was just luck. It was actually just luck.
Oh my
Otherwise, I
goodness.
probably would have done physician's training and ended up doing hematology and palcare or something like that.
Yeah.
Yeah.
So obviously no regrets with your decision.
No, worked out to be perfect, because it's kind of an interventional specialty in a way, but you work as a part of a large team, which I really enjoy. And it's actually a very interesting and creative specialty in many ways. So it suits me very well, though I didn't know it at the time.
Another happy accident.
Yes. Yes.
So Fiona, just for people that may not know, you mentioned that you're a clinical academic. How does that actually come about when you're a more junior consultant and sorting out your career path? Was that something that just sort of happened by accident, or you actively sought out to have that sort of role?
I think, to be frank, it takes a lot of tenacity. And I think the hardest thing is to actually know who you are and what you want to be. Because, most rad-oncs, baby rad-oncs, they're working in departments where there is not a lot of academic work, particularly not the kind of academic work I do. And so I think for me, I really enjoy clinical medicine and I find it tremendously rewarding. But honestly, I needed something else. And the something else I needed, I think, was the creativity and the risk. And also, to be honest, I looked at my personality and what I was good at, and I could just see the way I was going to make the biggest difference to my patients was not in the clinic. The way I was going to make the biggest difference to my patients was helping them in the clinic, understanding their problems, and then finding a solution to their problems through my research. And that was something I just felt very, very drawn to. And once I realized that I needed that end goal, I think I systematically put myself into places and made choices and took risks. So, to be frank, when I was doing my PhD, I had a staff specialist position and it was a full-time position. And I could see it was not going to be feasible to become an academic. So I had to make a decision. And one of the decisions I made was to stop working full-time and to stop working in the public sector for a short period and to work in the private sector purely just to, keep enough money coming in so that I could take the risk and finish the PhD. And it was in that 6 months that I got the phone call from Trevor. So I can't say that that's, karma or whatever. It is also just opportunity. But I think Trevor would not have called if he hadn't known I was interested. You have to show that you're committed. You have to show that you have what a friend of mine calls stickiness in research, because you're going to fail many, many, many times. And most of success, I think, in research is actually temperament. It's the willing to put yourself out there and to reframe failure and see it in a different way, and to be excited about the possibility and the creativity of it, even when it doesn't work out. So I think it's both. But I do think I was lucky in a way to find good people who would listen to me and who supported me and who didn't just say why. I mean, I must admit, I did have clinical supervisors who said, why do you need to do a PhD? I mean, honestly, as a rad-onc, it's a waste of time. And, most of them actually are academics and have academic titles. But I knew that's not what I wanted. And I knew that to do the kind of science I wanted to do, I would have to do a PhD. I would have to make choices about what I wanted to do with my time. And also at the same time, I had kids and a family and I wanted to have a life. And you can't do everything. Yeah, as you know.
Yeah. I mean, I'm incredibly impressed by your insightfulness, Fiona, to, at obviously a fairly early stage of your career to really appreciate what your skill set and your personality was and guiding yourself in that direction. I don't think everybody has that career stage. So that's really wonderful to hear. You mentioned that many radiation oncologists don't work in an academic or a research environment. I guess that brings me to one of the questions I had for you about unique challenges to undertaking research in radiation oncology.
Well, I mean, what I will say also is that I do think I am very privileged to work in a center where we work with many, many people who do not write grants and are never the first authors on papers, but who I consider to be really fine academics and also contributing significantly to academic work. So I think it's a mentality. You can be engaged with research and interested in research and supportive of it wherever you are. What I would say is that, at least in the past, the training of many radiation oncologists has been quite service-driven, is my perception anyway. And the college has made a lot of strides to improve this. It's mandated research requirements. It's tried, and I think is now doing pretty well with an intercalated PhD program to allow research in rad-onc as well. I think, generally speaking, there's a lack of investment in radiation oncology research. We don't get pharma funding. There is not a lot of biological research in radiobiology anywhere in the world, but in Australia we have very, very little. And I think on the whole, we don't have the mindset of engaging with research at a trainee level. This is not just in Australia. I mean, I wrote an editorial for the Red Journal, which is the American journal for Astro, and we looked at diversity in research in radiation oncology and in America. And in reality, 98% of the people who receive research funding for their talent program are male and white. And of the women who get in, nearly all of them have gone to Ivy League universities. Research is expensive. You know, I had to make a decision to work part-time, and it's an expensive decision to make. And I couldn't have done that without a lot of financial support from my family. And, you know, I think many people do not have those opportunities. And it's still harder, much harder if you're a woman, much harder if you have any caring role, much, much harder if you come from a minoritized group, which is not engaged in academia and doesn't necessarily have a social structure which supports it. So many, many personal as well as environmental reasons for why radiation oncology, I think, still suffers from a lack of support for talented researchers. Yeah.
Do you feel like the change in the training program to encourage more research, are you starting to see the more junior radiation oncologists come through and having an interest in research, or do you think those other barriers really need to be broken down to help with that influx of researchers?
Well, it's a little hard to say from my point of view, because when junior people come to me, they usually come to me because they're interested in doing research. On the other hand, I would say that I think on the whole that there's more and more trainees who are interested in research and are interested in different kinds of research as well. So, you know, stepping away from our normal strengths, which are sort of like physics and imaging and maybe data, which are kind of like very much in our work environment on a day-to-day basis, and thinking a little bit outside the box. It's still unusual to have somebody come to you and say, I'm a radiation oncologist and I want to work in a lab, because it's almost like a totally different skill set and temperament to doing both. But you do occasionally find those people, and they're very important. I think we have to keep working really hard at lowering the barriers and supporting talented people, whoever they are and wherever they're from, you know. And more, we, you know, in this day and age, and given what's happening in the research environment internationally, I think it's clearer and clearer how important that support is.
Yeah, absolutely. I was going to change tack a bit and talk about lung cancer specifically. I can certainly vouch from a medical oncology point of view that it's been an amazing decade and a bit in terms of advances in treatments for lung cancer. What are the most significant shifts that you've witnessed in the radiation oncology field in lung cancer?
Well, you know, it's kind of like it's just changed so incredibly. It's been a wild ride, I think. Because when I started training, the conversation in the lung cancer clinic was very much, even for radical patients, that, you know, we're expecting a 1 in 5 chance of survival long term, and we had very limited tools to think about curative treatment for patients. And the majority of patients we saw were getting short-term palliative radiotherapy, and it was very much an in and out situation in terms of planning and treatment. And what's happened in the meantime is this sort of exponential explosion in technology, in imaging, so that we can deliver really high dose, high precision treatment safely to more and more patients. And that's expanding to the metastatic setting. So now I'd say a significant amount of my practice is treating patients with oligoprogressive and oligometastatic disease, integrating that treatment with the systemic therapy given by their medical oncologist to either extend their therapy or sometimes in an evidence-free zone to try and potentiate the effect of immunotherapy, which we'll talk about later. So that is very exciting. And, it's really, really fun because most radiation oncologists are nerds who really enjoy planning. So, that's a fun thing to do. We're quite procedural in that sense, right? I think the other big thing has been the recognition that we can't act in isolation, that we are actually part of a clinical team and that we have to work with patients who are also getting systemic therapies and work with medical oncologists and surgeons as well, and to really deliver the right care for our patients. And so, the impact of the TKIs and immunotherapy has just transformed our practice in ways which I think were unimaginable when I started practicing as a radiation oncologist. Yeah.
No, absolutely. You mentioned new technologies. What sort of new toys have come your way in the last 5 to 10 years?
Well, I think obviously SABR is the big one, high precision, high dose radiotherapy to small moving targets. And I made a joke that we could SABR almost anything. And it's not true, of course. But the reality is that it has really changed the way we practice. And it also meant we can offer really precise treatment, which we know is almost certainly going to control disease. And in a way which is very palatable for patients because it's short. But, on the back of that, I think like image guidance and the ability to do complicated modulator plans where we can shape the fields very precisely and treat really big tumors. And so, there are very, very few locally advanced tumors which cannot now be encompassed by a radical radiotherapy field. Whether or not that's always a good idea from a clinical point of view is a different issue. But that was not a problem we had when I started. And then I think the other big advance has been the integration of other forms of imaging, particularly PET. And I think PET for staging, for planning, has really transformed the way we practice. It's made us better at staging, better at patient selection, better at planning. And it's helped us to understand the biology of what we treat in ways which I think really are also transformative for our practice. So they would be the big three, I would say, from a technological point of view for us.
So, Fiona, you mentioned the importance of a multidisciplinary team meeting. I guess one of the big shifts in lung cancer management has been the advent of neoadjuvant chemotherapy, immunotherapy, and surgical resection, and debates and discussions around resectability. Traditionally, I think it's been fairly clear-cut which patients were the chemoradiotherapy patients and which patients were resectable. Without wanting to dob it any colleagues, are you finding MDM discussions are becoming a bit more robust about patient appropriateness for certain treatments, or is it still fairly clear cut?
Well, I think it's changed, yeah, definitely. But also, I think it's also interesting to see, I remember discussing the Albane trial and trimodality therapy as a registrar and the excitement around that until you realize that 40% of patients never got to surgery. We have a little bit of this sort of happening where there's, I think there's a lot of dancing back and forth and understanding who this treatment is really right for because the neoadjuvant chemo IO, it's tough on patients, particularly older patients. And we do see patients tank out and never get to radical treatment. And there is not randomized evidence to show that those patients would not be better off with chemo RT, which they might cope with better. That's not easy either. Yeah, so there is a lot of going back and forth and nuance. And what I would say is that I don't know if it's become more robust. I think it always needs to be robust, probably, but it also needs to be respectful, which it is, at least in all the MDMs I have the pleasure to work in. And sometimes, unfortunately, entertaining because we learn a lot about ourselves. But that's all good, and I think this is actually the measure of a healthy clinical MDM. When you can have hard discussions and can, as a team, help to make decisions which will help that patient. So that's normal. So I don't know. I think there was a bit of anxiety initially, but hey, the landscape is always evolving. the newest trial I saw a trial, Jurushka Naidu, who's a med-onc. She tweeted about this. I shouldn't say tweeted. She put on that other social media thing about this trial where somebody had done neoadjuvant radiotherapy as well, or some sort of wacky what I would be considered a little bit unusual combination, but it's a randomized trial. And, the radiotherapy works. And her headline was, "Radiotherapy fights back." And I thought, it's just never going to end, really, this discussion, because things are always changing and evolving.
Absolutely. Yes. I think we've all are going to have our roles to play at an ongoing basis. So I think there's enough work for all of us, unfortunately,
more than enough
for patients. Yeah, absolutely. So you've alluded to some of these already, but what are the clinical challenges that as a radiation oncologist you face when treating lung cancer patients with radiation?
Look, I think the big thing which has really changed is just the advent of ongoing systemic therapies and understanding the interplay in terms of side effects with that, and being mindful and aware. Because during radiotherapy, we see our patients quite a lot, and sometimes we're the first people to find out they're unwell, which is, to be frank, something most radiation oncologists are not used to generally. And so I think that's one of the clinical challenges, and being respectful of the accumulative toxicity that you can have, and having really clear lines of communication with the patient, with your nurse manager, nurse clinical consultants, and your medical oncologist about what is going on. So I think that's probably still the biggest shift, and something I think our registrars also, even though they learn about it, it's hard if you haven't. Some of our registrars have not done physicians training. In fact, most of them have not done a physician's term, and so it's intimidating coming to terms with all of that on top of the radiation oncology. But I think that's important. So they're the biggest things, I think, mostly because they can make our toxicity much worse. So pneumonitis is obviously the classical example. And so just being, I think, very mindful of what is safe, what are established guidelines, when you are reaching the limits of your knowledge, and when to ask for help, I think they're very important things to do. Yeah.
Do you think that there are very clear guidelines in terms of what to do with radiation, with immunotherapy and tyrosine kinase inhibitors, for example? Do you think a lot of it has been collection of real-world data and people developing their own practice?
Yeah, I mean, I'd say the latter, frankly. I mean, there are guidelines which we follow and which are published, but when you really drill down to it, there's not a lot of data. And that's partly because, first of all, the trials already, there have been very few prospective trials combining radiotherapy with any of the newer agents, deliberately, I think, because those trials were designed to show the efficacy of the newer agents and of the newer systemic therapies. And so there's a paucity of information about radiotherapy-induced side effects in those combined modality treatments, which is difficult and sometimes a bit scary when you see things which are unexpected. Yeah.
Yeah, absolutely. And I think, even as medical oncologists, we're coming to grips with that as well, as new therapies come through, and the toxicity is always higher in the real world patients than what you see in the clinical trials.
Absolutely. Always.
Yeah.
Right.
So I'm just going to jump now, Fiona, I mentioned in your bio that you're on the board of TROG and that you lead the lung cancer subspecialty group. Could you just elaborate a bit to listeners on how that came about for yourself, and if people that are interested in pursuing that sort of pathway, what recommendations you would make for them?
So I took on a role in TROG as chair of the Lung Working Party in 2016, and I think joined the board shortly after that. And I think what happened at the time, two things happened. I'd been involved in lung cancer research for a while by that stage. So I think I started working as a staff specialist about 2013 or something like this. But I was doing a PhD in lung cancer, and I was involved in clinical trials and involved in TROG. But at that time, TROG structure was quite different, and it didn't have separate streams for each research group. And it was setting up its working party sort of bodies and thinking about who would lead those. And so I think actually, I can't remember whether they asked me first or David, but David Ball and I were asked to take on the leadership for this TROG lung group. And I was very junior at the time, and I felt very junior. And I remember asking David if he would do the chair, and he's a wonderful mentor, which, he talked about later, but he actually suggested that I take on the chair and that he would be deputy for that first few years. So that is how that came about. So I was very fortunate to come in at the ground and also to have a wonderful mentor who has the great gift of stepping back and letting you learn how to lead and learn how to manage people. And anybody who knows David knows that he's a very generous and funny and well-rounded human being as well. So it was also profoundly human in his ability to manage complex situations and personalities, which you definitely get when you're discussing people's babies in a research setting.
Yes.
Yeah.
That sounds like the perfect situation, having someone, like you said, that's willing to stand back and let you take the lead, but having their expertise and wisdom, to guide you when you need it. It doesn't always happen like that. That's amazing. And
I was very
kudos to David.
Yeah. And the board role, I think at the time also, I think they were to some extent looking for new people on the board. So I nominated and was elected to the board at that time. And TROG, I think, has a fine tradition of supporting and mentoring early to mid-career academics into its leadership structure. And it's one reason why it's been such a long-standing and successful organization, because it's able to bring in innovation in that way. So I think also that was a very fortunate situation. Yeah.
So I guess for more junior radiation oncologists, maybe trying to get into committees and that sort of thing as a stepping stone to...
For sure. Yeah. I would say, like in our lung working party, it's actually not a very big group of people. And we're always keen to look for new people to join. And TROG is multidisciplinary. So, of course, we welcome medical oncologists, imaging, physicists, allied health, as well as radiation oncologists. And any of those people, if they're members, can propose trials, can be involved in governance, can be involved at a board level as well. We appoint people to our board. It's a multidisciplinary board. So I think being involved is the most important thing, and doing enough to figure out kind of like what you like, because to be frank, you're probably going to figure out if you enjoy being on a board and discussing financial management or not pretty soon. So I think figuring out what your skills are, but you have to try things to do that.
Yeah, absolutely.
But being involved, yeah.
So, Fiona, you've mentioned Paul and David as mentors. Who else has been an influence in your career?
Yeah, I mean, I think I really have to single out Michael McManus, who's been the most wonderful mentor. And Michael is an amazing academic in his own right, particularly, I think, well known for his studies in lymphoma and in PET, which have really established the role of FDG PET for staging of lung cancer, but also really established a whole paradigm of radiotherapy treatment with low-dose radiotherapy for follicular lymphoma with great publications. Apart from being an amazing human being, a very creative and talented academic who is great fun to be around. And Michael and I have breakfast every Thursday morning after the lung NDM and hatch plans for research and catch up and talk about whatever is going on in the Parkville precinct and elsewhere in the world. And we always come away with new ideas. And he's also a very generous person who, like David, is very happy to step back and enjoy the success of the people he's mentored. So he's been amazing. And, at Peter Mac, I guess I've been so fortunate to work with other people, biologists like Kate Sutherland, who's been wonderful and generous, and Sarah Jane Dawson, who's an amazing medical oncology academic and in the translational space, as well as being a very fine clinician. And those people have been wonderful mentors, supporters, and models, I think, for me academically. Yeah.
I think it's it makes work a very fun place to be when you're surrounded by good and inspiring people.
Totally.
Yeah. Fiona, we're coming close to time, but I guess I'll just finish by asking you, what would one piece of advice be that you would give to trainees or early career colleagues?
I would say be true to yourself. I mean, it's sort of I could say whether it's right or not, it's what's for me, and in the sense of what I mean by that is take the time and the bandwidth to know who you are, what you enjoy, what you're good at. I mean, I choose to work in a particular academic environment in a large cancer center. I have wonderful colleagues who choose to work in rural practices and practice general radiation oncology or general oncology, and they love what they do, and they're very, very good at what they do. And I think at the end of the day, recognizing that work is only part of your life and that you're a human being as well, and it's important to be happy and productive at work. And to do that, you need to be true to yourself and be able to align the rest of your life and your values together so that work becomes part of the whole. not something which takes away or detracts from the rest of your life. That would be my recommendation. It's not always easy to follow. Sometimes you need to put up with a lot of pain to get to where you want. Wasn't easy having kids and doing a part-time PhD. Kind of sucked, really. But at the same time, I think if you keep the end goal in mind, life to some extent gives you what you, or it has anyway, given me what I needed. So that would be my advice. Yeah.
That's some brilliant words to finish on, Fiona. It's been a real pleasure having a chat to you. You've been incredibly insightful about, where you saw your career going, but also accepting of the challenges. And I think there's some really great pieces of advice and inspiration for listeners, both in radiation oncology and across the board. So very much want to thank you for your time after the end of a busy day, Fiona, and it's been a real delight to speak to you.
No, it's been so much fun. And Mel, I think we worked together briefly at Liverpool Hospital many years
did.
ago.
I was a mid-onc-advanced trainee.
I remember you.
And you were there, yes.
When I realised who you were, it took me a while after I came to Victoria. I thought, oh, that's nice.
I know. Come full circle. So thanks again, Fiona. And that brings us to the end of this episode. As always, thank you to our listeners for listening to TOGA's conversation in lung cancer research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify. And look forward to you listening again when we next meet. Thank you.